Hello, good afternoon, good evening, and good morning to everyone joining us today for the weekly Ask WHO session on COVID-19. We do apologize for starting late and also for being only live on Facebook platform today. We are experiencing some technical problems, so we couldn't stream on multiple platforms as usual, but we are hoping that for next week everything will be fixed. I'm very pleased to be joined by Dr. Mike Ryan, who is back, and also by Dr. Abdi Mahamud, who was with us also a couple of weeks ago together with Dr. Maria Vankerkov. If you're watching us, actually you're watching us only on Facebook today, so please send us your questions using the comment section and I will pass them to Mike and Abdi. Good afternoon, Mike. Good afternoon, Abdi. Thank you for your time. Maybe we can start with COVID-19 epidemiological update, because we are seeing that in some countries we have increased in cases but also hospitalizations. So maybe you can provide us with some summary of hotspots of transmission at the moment.
Thanks, Alex. I will start and Mike will add. Overall, globally, we are seeing, despite slow trend that was going down in the last 2 weeks, we have seen an upsurge. Almost this week, close to 20% increase in the number of cases reported. That took almost around 4.1 million cases, and with a different variation, which each region will explain more. And the death, we always say death is a slow indicator. It moves slowly, with also death global reported around an increase, making around 8,500 cases reported last week. In terms of the region, each region and each country, depending on the immunity landscape, we will see different how the new variant. So in the East Mediterranean region, we have seen upsurge of cases, particularly in Lebanon and Pakistan. The government warned that they may go into the 5th or the 6th round. In Western Europe, several countries have seen increase in the number of cases on hospitalization, and some of them are coming off the wave, particularly Portugal that had the early BA4, BA5, but we are seeing a similar trend in the UK, where the number of hospitalization has increased in the last, continuously increasing. Moving to the Americas region, America continued increased trends. The BA1, the .121 was increasing, but now there's an introduction of BA4, BA5 that's increasing hospitalization. And it's not limited, but across in South America, we are seeing more trends like this, Brazil and Peru and several other countries. In Southeast Asia, we haven't seen uptake, but the level of interconnection, big cities like Mumbai, are seen also increase. So countries that are well connected, or cities, may have experienced in the initial wave of BA4, BA5. China's situation is calm right now, although there's more cases coming in terms of the population, the way they're testing. Globally, we are seeing that dramatic decline in the number of testing, so it's very hard to compare the numbers, what we are seeing, but initial indications from the countries that has good data, we are seeing more and more cases being reported, infection followed by hospitalization, and a slow increase in death. That's where we are now globally.
We can, a couple of weeks ago, we did have decrease in death rate on a weekly basis. This is not the case anymore. Do we see increase in comparison to last week?
Yeah, overall, yes.
Overall.
We are seeing an increase of 3%. We reported average 7,000 cases, but now 8,300. So few countries are driving that, particularly in the United States of America and Brazil. US reporting around 2,000 cases a week, which is still a big number, and with Brazil 1,300, because these countries may have a better and experience the initial wave. So overall, we are seeing 7,000 to 8,000. But if that trend continues, if what we saw Portugal early on, when they have the early introduction of BA5, we may be seeing more and more death increasing in the coming weeks.
Thank you so much, Abdi. Mike, would you like to share any comments on this situation at the moment?
It's always a worry when you see Europe, Southeast Asia, the Eastern Mediterranean, all increasing in 1 week by over a third in confirmed cases. And that's, as Abdi said, in the context of decreased testing. So when you start to see a trend going against the testing, so testing is going down, but we have over a 1/3 increase in cases in a week. in 3 regions around the world, I think that's time to sit up and take notice. Transmission is definitely increasing. There's no question that transmission of the virus is increasing. But what we're seeing then is divergent outcomes for that. In Europe, and it remains to be seen, but we still see fairly low hospitalization, fairly low death rates, probably reflecting high levels of protection from multiple doses of vaccine. That may not be the case in the Eastern Mediterranean and other places where vaccine coverage, particularly in highly vulnerable people, may not be quite as high. And I think we've seen this play out again and again and again. This virus, regardless of being more transmissible and potentially with people having some background immunity from natural infection, the reality is that when you have a wave of infection of whatever variant we've had all the way through, when you have a wave of infection that passes through a community that has low levels of vaccine protection, you get a rise in hospitalization and you get a rise in death. The question is whether that system can handle that. And whether countries are willing to accept that. Are countries willing to accept that every time we have a wave of disease, we're going to see increases in fatality, increases in ICU admissions? Or are we really going to focus on addressing the real gap here? And the real gap is in many countries, we still have not vaccinated the most vulnerable with 2 to 3 doses of effective vaccine. We've proven the vaccines are effective. We've had the most amazingly speedy development of vaccine countermeasures in the history of humankind. Those vaccines have been deployed to a great extent all around the world now, although with huge inequities in the speed of their deployment. But they're available now everywhere in the world, and we need to make sure that the most vulnerable people, particularly people over 60, people with underlying conditions, people with immunocompromised, people that need these vaccines need to have them, because this virus has not lost energy. You can see it every time we see a new variant emerge or we see subvariants emerge. By definition, they have to be more transmissible because they have to outcompete the previous. In order to survive, they have to be better at transmitting, and in that sense, they become more transmissible, more successful. So in doing that, it just means we're going to see that. With waning immunity, as after 6 months or a year, immunity tends to wane a little, protection tends to wane a little, certainly from infection. We're not, protection against hospitalization and death seems to be maintained to a great extent. So the reality is that not enough people are vaccinated. And certainly with some of the vaccines that require 3 doses to really have full primary effect, we don't have enough people vaccinated yet, and we need to increase that. Some governments are making decisions, I think, Abdi, to introduce 4th doses for the most vulnerable people, and again, there isn't a huge amount of scientific evidence to support that. I mean, the scientific evidence certainly supports that in vulnerable people, a 3-dose regime seems to give an extra layer of immunity, although 2 doses of an effective vaccine gives very good protection. In a vulnerable person, 3 doses seems to give a little extra protection. We don't have clear evidence on that 4th dose, but there is logic in suggesting that after a period of time you give a 4th dose as a booster. But again, I'm very comfortable that people have 3 doses of vaccine are going to do well if they're infected. What I'm still concerned about are 0-dose people. People out there with vulnerable underlying conditions, people out there who are older, who remain unvaccinated, they still remain hugely susceptible to the negative impact of this virus. And I don't know if we're doing enough to find, convince, and vaccinate those people.
Thank you so much, Mike. What are, in your opinion, drivers of this transmission? Abdi, you mentioned the BA.5 sublineage of Omicron. So maybe if this is the main driver of transmission at the moment, you can provide an update. And we've seen in some news that there were headlines, this is a new variant, but it is not a new one. It's a sublineage of existing Omicron that's been with us for a couple of months now.
Yeah, I think as Mike mentioned earlier, people confuse the variant with the evolution of the virus. That's one side. But the one on our side is the population immunity, what we have done to build that wall, the defense wall. So it's easy to go down the rabbit hole of BA5 and how many micro different it is. That's for the science determine that and which one is driving. But each country will have a different immune landscape. the same variant will come to one country and it will go mild, and we'll say, oh, it is a mild, and we'll relax, even as we suffer from that confirmation bias. So I really want all the scientists and the policymakers to shift and look inside each region. What's the immunity landscape? How does it lie? How does it, so that you make the best decision. So making a calculated, or looking how this virus, I'm talking about BA4, BA5, it went through South Africa, which was relatively milder compared to the BA1, BA2, and they had early in December, January. When it came there at the heel of another big peak of multiple infection with a young population, it was a different picture. It came to Portugal, which 6 months, 8 months after the last booster, where people relaxed, it had a different trajectory. So high-risk population, elderly population in one country, the same variant will have a different trajectory of that. So I think it will be very, very important to shift away from variant focus. These are variant will do what they do, as I said earlier, it's a competition between us, the race. But evolution is one factor of biology. I think it was Ukrainian, Russian scientists who said you can't understand biology unless through the light of and the spectrum of lens of evolution. So it's a fact that this virus have to outcompete each one of them. So we started with Omicron, BA1, BA2 had to outcompete that one, BA4, 5. So each one of them has to outcompete, and a new one will come. But how the impact of that wave will be, was the population immunity. How much of your vulnerable population, of your people with comorbidity, with elderly, are vaccinated with appropriate vaccine, and when were they vaccinated? So I will really stay away from this. If people love, oh, it has 17 nucleotide change, it has that. But what is inside? The virus will do what it does, but the immunity wall and the immunity landscape of each country and each region needs to be assessed, and appropriate measures need to be taken to protect the health system and the vulnerable population.
Abdi's point is well made, because we make a false assumption that it's because of the subvariants or the sublineages that we're getting the increased transmission. That's not necessarily the case. It's more to do with the length of time in between that allows people to lose some immunity for transmission. The viruses are competing, and they have to be more transmissible because they're competing with each other. It doesn't mean that the next virus is more infectious than the others. Some of them can be more infectious. They're just more transmissible, means that they're more effective at establishing an infection in the next individual. But it's also that waning immunity in that gap, as you said, waning immunity in those already vaccinated or previously exposed, and the actual gap of people never exposed, either to the infection or to the vaccine. What we don't want to do is, in some senses, the virus has its own arsenal, its own weapons, and we have our defense. And sometimes we look too much to the virus's weapons, and we make all our decisions based on that. And we say, well, actually, we need a defense. We need a defense against multiple variations of that virus. We need to build a common defense. And our common defense is our immunity wall, as I think it's a great word you used earlier, that wall of immunity, and look for gaps in that wall. Because by having clearly strong immunity across the whole population, we're not just protecting individuals, we're protecting vulnerable people within those communities. We're creating a safe space for everybody to live and work in. And if you leave huge gaps in that, then you make certain parts of your population very, very vulnerable to negative outcomes. It doesn't mean the virus won't come in and potentially spread around. It can happen, because the vaccines we have are not perfectly effective against infection. But what they're very effective against is hospitalization and death. So that focus both on continuing to track the virus, and we need to continue to track the variants and the sublineages. We need to not be fighting this blind. And the drop-in testing is concerning not only because it reflects a lack of interest in some cases of following this, but also it makes us blind to where the virus is and how it's developing. So keeping up surveillance is going to be very important. But also then using that surveillance to know where the virus is, know our immunity gaps through making sure we understand who is vaccinated, who is not, down to the house and village and street level, and just looking at blindly at things like vaccine coverage. I mean, I can say my vaccine coverage is 60%, or I can say my vaccine coverage is 90%. That sounds great. But if my overall vaccine coverage is 90% in the whole population, because I've vaccinated 100% of 25-year-olds, but I've only vaccinated 50% of people over 60, then it's not a great vaccination campaign. Vaccination campaigns are successful when you vaccinate the targeted population very, very well. And the primary target for vaccination in COVID are older persons, vulnerable individuals with underlying conditions, frontline health workers. They're the three categories that we consider to be most vulnerable to infection. And if we're not vaccinating them, we're really not doing the job. So we can't hide behind big numbers that look good, when in fact underneath that is, myself and Abdi worked for years, Abdi more than me, in the polio program. And it was exactly the same issue at the time, if you remember, Abdi. Everyone was focused on 100% coverage at 100% coverage. And, 100% coverage means that you know the denominator population, and sometimes in the countries we worked, there was no census. So you couldn't use that. Well, we worked very closely with our colleagues in country, some very brave people, by the way, and very gifted people, on shifting to looking at zero-dose kids. Because we kept vaccinating the same kids. Remember, the same kids were getting vaccinated 20 times. But the same kids were being missed every time. So we had this group of 5 or 6% of the population of children that we were not vaccinating. And that's what's prevented us eradicating polio. We now stand on the cusp of eradicating polio in the world. Only the second disease will ever be eradicated. Is it a lack of vaccines? No. Is it a lack of vaccination campaigns that stops us? No. The only thing that stops us eradicating polio off the face of this planet is that we cannot reach zero-dose children with 3 doses of effective oral polio vaccine. And it's almost the same story again in COVID. The thing that prevents us exiting the emergency phase of this pandemic is our inability to reach all vulnerable and older persons who have no dose of vaccine with at least 2 and hopefully 3 doses of effective vaccine. And it sounds so easy to say. And yet, with that reality, we're absolutely obsessed with minor changes in the virus, and we're obsessed with all of the science, and that's great. I'm obsessed with scientists myself. But sometimes you have to move away from that and focus, as Abdi said so correctly, on what is our problem. That's the science, but what's our actual problem? And our actual problem is we haven't vaccinated the people we need to vaccinate everywhere. If we can do that, then I think we can avoid the repeated waves of hospitalization and waves of death as we go through the rest of the year and into next year.
Thank you so much, Mike. And you are talking about those vulnerable groups and targeted groups that need to be protected. And we also heard from Abdi that cases and hospitalizations in many places are on the rise, where we actually have the tools and means. So we've been receiving questions about summer starting in Northern Hemisphere, and we see in many places that everything looks like post-pandemic. So how do we encourage people to protect themselves when they live in environments where you have the impression that the virus is not with us anymore?
Maybe Abdi can follow, but one thing I think, some of the data that's emerging now, and it's not it's early data, but certainly there are data emerging that would suggest that getting multiple sequential infections with COVID is not a good idea. People get infected. So, well, I've been infected now. It's fine if I get infected again. It's quite clear in the data that if you get infected now and you get infected again in 3 months' time, or you get infected again, even if you're not very sick, that actually increases your risks of having long COVID or having post-COVID complications or post-COVID condition, particularly to do with cardiovascular and other diseases. So I think it's very important for us to recognize that even though with vaccination and even with everything else, it's just not a good idea to get infected with this virus if you can help it, because we don't know the long-term consequences of one or multiple infections, first of all. So if you can avoid the infection, please do. But we also recognize that we have to get on with our lives. We recognize that kids have to go to school. We recognize that people have to return to university. People have to go to work like we are here today. So we have to find this balance between the social, economic, and psychological need for us as human beings to interact with each other, and the desire to avoid being exposed to this virus for personal reasons and to stop chains of transmission. So can we find a balance between those two things? And I think that's the issue for the summer holidays, is to look at your risk register for your trips or your holidays. If I'm traveling, if I'm in the bus, I'm in the train, wear a mask. You know, be careful on your hand hygiene. If you walk into a bar or a nightclub or restaurant and it's completely packed and there's no ventilation, why not sit outside if you can? So make smart choices. But in reality, the way the world has gone back, you know, you have to go to the local store. I went to the local store in the train station here last night, and it was chaos. It was just so many people there, a summer's evening, and I thought to myself, oh God! And I knew if I went to the other store, I was going to have to walk about 150 meters, 200 meters the opposite direction. But I chose to go to the other store, and I went there. Very few people. Now it cost me 2 minutes walking. Abdi says I need to walk more anyway, so it's good. But I made a choice not to go into the store that was very crowded. I just made a choice. Now, has my risk gone up or down because of that? I don't know. But my own risk register says I still wear a mask. I come to the work on the number 8 bus every morning, and I still wear my mask on the bus. I'm not I'm not being paranoid. I'm just making a decision that I'm sitting in a place with 50 other people in a closed space without ventilation, so I'll wear the mask. But I'm not wearing a mask with you here today because we're properly distanced and we're in a big room with good ventilation. So I'm happy with that. So the more, as governments have reduced the restrictions on society that are the rules, it doesn't mean that you can't manage your own risk. And I think that's the only way to do it, is to look at that. And particularly, if you're someone who's older or someone with underlying conditions, there's a great, I have a really good friend at the moment who's fighting cancer, and he's an incredible guy. And, I see him managing his own risk. He still wants to be out there in society. He still wants to be engaging, but he knows the consequences for him of getting COVID are much higher as someone who's on chemotherapy. So in that situation, if you are vulnerable, please do not be ashamed, and do not, please, your health is important. And if you walk in, I've seen people challenged for wearing masks in a shop, so you don't need to wear a mask. You don't know that person. You don't know that that person isn't on chemotherapy. You don't know that that person isn't caring for a vulnerable person at home. You don't know that person doesn't have a child on chemotherapy at home. So please, when you see someone wearing a mask, don't make fun of them. They're wearing that mask for a reason, because they're probably caring for a vulnerable person, or they're vulnerable themselves. So it's really important that we support people who continue to take precautions, even if we feel we don't have to. That's number one. Number two, if you can avoid the infection, please avoid it if you can. And number three, just look at your risks. You don't have to hide under the covers. You don't have to isolate yourself in your home. But, choose where you are, choose where you go. If you can eat outside, eat outside. If you can wear a mask on public transport, wear a mask. I traveled on a plane the other day. I would wear a mask on the plane. Some airlines still require the mask, some airlines don't. I just wear the mask all the time. I feel more comfortable. It's no imposition. It's not a problem for me to do that. So it's the simple things. I don't know, Abdi, if you have anything to add, but just simple decisions. Manage your own risk.
I think you covered it very well. I mean, a lot of the holidays are outdoors, so prefer outdoor activities, a lot of more safer, more reduced risk than indoors and we have seen the world is so interconnected. It's not only one disease, it's multiple diseases going out there right now. So how do you personal protections, protect yourself and your loved one, and then making sure your vaccines are up to date, not only the COVID vaccine, but other vaccines wherever you're going, and then the referral system, because people travel a lot without information. So we have incredible, powerful tools right now, the antivirals that are available. So making sure that you're updated and you take the necessary precaution measures. When you pack your bag, you make sure you have your passport and everything. So please do add now COVID and other public health measures in your checklist, so that where I'm going, because there's a reality, the disease the way we are seeing uptake in most countries, you may end up in a country with upsurge where the hospitals are overwhelmed. So making sure you take almost all the precaution measures as you do for all the fun thing you want to do it, but make it more fun, but also safe for you and your loved ones.
Thank you both. We have a question, I believe, from someone who is a football fan and worried if COVID pandemic might create problem in the upcoming FIFA World Cup in November. So maybe we have some guidance for mass gatherings on how to mitigate risks in such events.
No, and we've been through that. We've worked very closely with the Olympic movement, with religious movements, with everyone that's managed mass gatherings. And I must say that in the main, those organizations that have, nations and organizations that have set up and run many mass gatherings and events over the last 2.5 years have shown a great deal of responsibility, a great deal of willingness to plan, willingness to listen to WHO and national authorities regarding risk reduction measures, sometimes cancellations, sometimes reducing the density of people, sometimes increasing the measures of protection like masks or requiring vaccination, different measures used at different times. But I think what we found in the main is that most mass gatherings have gone on at a very high level of safety and protection and haven't contributed to overall transmission. Now, in the beginning, certainly there were some mass gatherings that did, there's no question. But we do believe that properly managed mass gatherings that have the proper planning and implementation and engagement in terms of risk reduction measures can be run very safely. And we would say that will be the same of the World Cup. We've been working very closely with the authorities in Qatar on that as WHO and providing advice as needed to them on how to run a safe World Cup. The public health authorities in Qatar itself have been very engaged. The Minister of Health there, she's an amazing leader in really focusing on not only on the public health risk management of the World Cup itself, but using the World Cup as a platform for health promotion and healthier lifestyle. So Qatar has done both quite well with FIFA. So I think overall the risks are being very carefully managed. I don't perceive there's any more risk with the World Cup than there've been with any other mass gatherings. And again, you see countries in the Middle East over time. If you look at the way Saudi Arabia, the Kingdom of Saudi Arabia has managed the Hajj over years, an incredible mass gathering. Millions of people come together, and they're run with incredible levels of public health risk management. I have every faith that they will be able to run a successful World Cup and that it will be a spectacle for the world to enjoy.
Thank you so much, Mike. You spoke about the importance of vaccinating vulnerable and in all parts of the world. So we have a question from one of our viewers about vaccination percentage of health professionals and vulnerable people in lower and lower middle income countries.
Yeah, it's a good question because it's actually much lower. If you look at Africa, for example, I think only about half of health workers in Africa have been vaccinated, whereas if you go to European countries, that exceeds 80-90% in many cases. So there is still a differential in vaccination. Certainly vaccination levels in health workers in low-income countries is higher than the general population, for sure, in those same countries. But overall, the level of vaccination in health workers in lower income countries is much worse than even the worst performing countries in the industrialized world in terms of general population cover. And that's really weird. That's really not acceptable. So your listener is absolutely correct. There's still a huge differential there. And some of that's looking at availability of vaccine, because remember, health systems in many low-income countries are they're not like many people who live in industrialized countries see the hospital and the clinic, and they see these centralized health services. Many health services in developing countries and low-income countries are very distributed out there with community health workers and others very deeply embedded in communities. And they very often have very few resources. But sometimes the system doesn't even know they exist. In fact, it's a big problem for the future of world health, that we're not focused enough on primary health care and on improving the training and improving the resources available to frontline health workers, community health workers and others. And I think if you look at these data, you'll probably find in many low-income countries that you'll find workers in the centralized secondary and tertiary system, the hospitals, are probably well vaccinated. And as you go further out into the community and into the community health worker side of things, you'll find they're less vaccinated. Because very often these health workers are part of their own communities and they suffer the same lack of access to healthcare as the communities they serve. It's an incredible and embarrassing and humiliating fact for the world that very often the people we rely on most, our community health workers out there, are very often as badly served with healthcare as the communities they try to serve, which to me is a problem. So yes, I think your listener is right, and we have to redouble our efforts. It's really, really bad at this stage of the pandemic that we have significant numbers of health workers in low-income countries that remain unvaccinated against this disease.
Thank you so much, Mike. We have another question about vaccines from James Hunter. Is there vaccination imprinting? And if so, what should we do? Maybe we can also explain what vaccination imprinting means for broader audience.
What does he mean by vaccination
imprinting?
No, I want to understand what the question he asked.
So the question from James Hunter is there vaccination imprinting? And if so, what should we do?
I don't know what he means by imprinting.
We can come back then to that question later. We've been having questions about vaccination efficacy as well, actually vaccine efficacy of the current vaccines, and in particular in this context of BA.5, if they are still working.
Just to explain, maybe I should have spent more time. We have to see the SARS-CoV-2 virus tree. So a tree has a trunk and then a lot of branches. So when you see the tree, and so each variant had its own branches. A big branch was the Delta, Alpha, and now Omicron with many, many branches and the trunks. So the current vaccine we have, because they're coming based on the ancestral, the trunk and the root, are quite effective in preventing the severe disease and protecting everyone who has received appropriate doses, whether it's 2 doses or 3 days. So that's very important understanding, because people get caught up on the branches when the forest and the trees. So what we have, the current vaccines are based on the original one, which all these variants are coming kind of as a branch, distant from each other, but all share the trunk and the base of it. So the vaccines are still effective. If everyone got it, we will not have been where we are, to protecting people against severe diseases and death and ICU admissions. What we haven't, in the initial time, the first 3-6 months, they may protect you against infection, but as Mike said, immunity over time wanes, and there's a new variant that can bypass that protection. So in short, the current available vaccines have shown incredible resilience and protection across almost all the studies done repeatedly for different variants. So what we are seeing more and more right now is the increase of kind of the reduction. If you have been vaccinated a year ago and now you get it, that protection level may have reduction by 10-15%. When you're boosted, it goes back to where it was 90 to 95%, depending on the vaccine type and how it was given. So the main message is whatever we have, whatever vaccines, really incredibly work in saving us from severe. There's some discussion going on. Should we be specific for certain variant and build? But all this is based on the trunk and the tree, the strength of that. So we may need more that can cover the breadth and the quality of that antibodies and the protection. But overall, the main message is available vaccines are safe, effective to protect us against severe. Research is going on. We had a WHO R&D blueprint convene a big research to discuss what's the next second generation and third generations. How can we deliver better vaccine that give us a long-lasting immunity against infection? As I said earlier, the current one does not. It protects the initial first 3 to 6 months. After that, it wanes. So you can get infected, but you are protected from severe disease and death. So this upcoming research, which a lot of them going on, is to have banned coronavirus vaccines that covers almost all the other coronaviruses that will target areas, section of the DNA or the RNA that are conserved. Some of them are under selective immune pressure, other part of it are conserved and they remain. That's why the PCR test, RNA, the rapid test are still working, because they are not based on the part of the virus that keep changing, they're based on the part that's conserved. So can we have vaccines, and the research is going on that covers all the coronaviruses, pan-coronavirus, so that can give you a long-lasting sterilizing immunity.
But it's not so straightforward. We've been searching for that unicorn in influenza for decades. So it on the face of it, it sounds straightforward, and it is from the scientific understanding, but actually finding and delivering on that is going to be quite a challenge. It's also, I hope we can. I know there are some in development, but again, it's very important that we're also, when you look at the success of this vaccine, using the ancestral strain, it is still providing huge levels of protection, and it's our best bet. And I don't know that your colleague who spoke before, when you talked about vaccine imprinting, was he talking about immune imprinting? Because I understand immune imprinting, and that maybe the question he was asking, because there is some data out there that suggests that if you get infected with a particular strain of a virus, or you're vaccinated with a particular strain of a vaccine, that can prime your memory B cells in your immune system and makes you less likely to develop immunity against other small changes in the virus. So in that sense, continually changing the vaccine strain may actually have its own particular limitations. Just chasing small changes in the virus may not actually increase immunity because of this concept of immune imprinting. I don't know if that's what your listener was talking about, and that's both from when you said vaccine imprinting. That also potentially occurs with natural infection. So I think it's better known as immune imprinting. So I think that idea that we have a very good vaccine that's centered around the ancestral strain. There are arguments that we could use some boosters based on a variant strain, which would broaden the breadth of immunity, notwithstanding that discussion of immune imprinting. These are all being discussed by the TAG COVAX, by many scientific groups, many publications coming out around that. Abdi is right. Having pan-SARS coronaviruses vaccines would be a fantastic development. The other is using a different way of delivering the vaccine, because delivering the vaccine by the respiratory route, by nasal drops, or by an aerosol into the nose might provide vaccination at the site of infection, and that could provide much better protection against infection with the virus, and also protection against the hospitalization and deaths. So you can improve the vaccine performance in many ways. You can improve the efficacy of your vaccination campaigns by reaching all the vulnerable people. You can improve the efficacy of your vaccines by making them more effective against multiple variations of the virus. Or you can improve the effectiveness of your vaccine by the way you deliver the vaccine, where you initiate the immune response. And so if you tweak all of those things together and you try and say, okay, maybe what we need to do is have development along multiple lines, we will eventually come up with a combination of approaches. And if you look at polio vaccination, is a good example. Every child that's born gets injectable, well, there used to be every child born got oral polio vaccine and got injectable polio vaccine. Injectable polio vaccine was to stop paralysis in a child. The oral polio vaccine was to stop the infection. When you get an injectable polio vaccine, it doesn't stop you being infected at all. I don't think it has any effect, Abdi, does it? If you want to stop polio transmission, you use the oral polio vaccine. If you want to stop the negative impact of polio in the body, the paralysis, you use injectable polio vaccine. Using the two together consistently over time in a population allows you to eradicate the virus and eradicate its negative impacts. And we may end up at some point in the future using a combination of nasal vaccines and injectable vaccines for COVID. And it might be a combination of the both that gives us ultimate control. It may not be, but that's one future. The other future is a more, as I say, a protective pan-SARS-CoV-2 virus. But in the meantime, while we're waiting for those, there's an awful lot we can do with the vaccines we already have. So I don't want us to be looking over the fence at all the things we could do next year or the year after. There's an awful lot we can do right now to find those people who have 0 doses of COVID vaccine and offer those vaccines to those people, because the current vaccines save lives. And the current vaccine has saved millions of lives, and it can continue to save lives. So as human beings, we're always looking for the next iPhone or the next version of a car, or, we're always looking to the next version of things, right? And that's great. We, as human beings, we're innovators in our DNA. We all look for that next thing, and that's great. But before we look to the next thing, let's please use the things we have to their best effect. So if we can do both, use what we have to best effect, and then look for longer term, better solutions, then we'll be perfect. And I think we'll be able to work our way out of the pandemic.
Thank you so much. We have the tools, but we are still seeing cases and hospitalization growing. So when you look into this third year of the pandemic, what worries you the most, and what is the way forward that you see in this outbreak?
What worries me the most is complacency right now. We kind of sleepwalk our way back into more waves of COVID without recognizing what previous waves have done. So we've been through it now. Everyone on the planet has been through, 3, 4, or 5 waves, and we've seen what each of these have done in our communities, in our society. We've seen who's vulnerable. We've seen who gets admitted to hospital. We've seen who dies. We know how to protect ourselves. We know how to protect our loved ones. So to go through another wave without applying those lessons, to me, would just be tragic. I don't think we have to go through the same experience. Now, that's notwithstanding the fact that the virus can continue to evolve and the virus itself can deliver surprises, no question. But most of the future trajectory of the impact of this virus is in our hands to a great extent. So I think this focus on vaccination, and also in addition, we keep talking about vaccination, the focus on continued surveillance, focus on vaccination, but also a focus on therapeutics. We have very effective antivirals now. We have to make sure the right people get them. These antivirals have to be given within 5 days of the onset of the disease. They have to be given to the most vulnerable people. So giving antivirals to perfectly healthy people who have a mild infection, I don't know if that's going to do any good. But giving an antiviral within 1 or 2 days of the onset of infection to a 70-year-old who has underlying hypertension and diabetes, that could be life-saving. So again, now we have antivirals in good supply. Are we going to ensure that each and every country that needs those antivirals gets them, and that the right patients get those antivirals at the right time? And the only way that can be really delivered in most countries is delivered through the primary health care system. Relying on hospitals to deliver antivirals to people, by the time they get to hospital in most countries, they're too sick and it's too many days. So we have to focus in on introducing that. Now, when we look at the likes of malaria treatment, and we look at TB and HIV treatment and others, and the work that PEPFAR, the Global Fund, and others have done with WHO, UNICEF and others, there are ways to deliver antivirals into the primary healthcare system. So you can have point-of-care diagnosis with antigen-based testing, and you can, on the basis of that testing, treat someone early who's got high vulnerability to COVID. Then we could save a lot of lives that way too. And I don't know, Abdi, what the latest numbers are on that, but I really don't think that we're properly set up to be able to use testing and use treatment at the primary healthcare level. Now, we're working very hard in WHO with partners in UNITAID and partners in FIND and partners in the Global Fund and others to see how we can accelerate that. So there's work to do. There still is work to do in both delivering vaccines to the subnational level and vaccine delivery and vaccine acceptance. There's still work to do on therapeutics and clinical pathways, and there's still a hell of a lot of work to do to continue to do surveillance and tracking of this virus. That's what the public health and health systems need to do, and the work is not done. And the complacency on any element of those will lead to unnecessary deaths in the coming months. At societal level, at community level, continuing to protect yourself, continuing to protect others, encouraging people to get vaccinated, and ensuring that the most vulnerable in society get access not only to vaccines but to good healthcare. If we can work on that, we'll do better. But complacency, for me, is our biggest enemy right now. Thinking we're finished before we're really finished. We also, what worries me going into the winter is the combination of having, as we've seen, increasing levels of influenza mixed with COVID waves, and if the two happen at the same time, you could have two relatively mild epidemics making a much more serious epidemic because the health system becomes overwhelmed, because you just have a lot of respiratory virus cases around. So planning to be able to manage an epidemic of influenza and an epidemic of a wave of influenza and a wave of Omicron at the same time, that's something we need to take into account in our health services planning in the coming months. Abdi, any?
I think the complacency is number one, number two, number three. But the main thing that's really coming along that's related to that at the base of it is the trust. That we've been lost again, and at individual level, at society, at government, that loss of trust and how to rebuild. I think the social scientists, anthropologists, and risk-coms can tell us. But leading that lack of trust, and the best tool we use is confirmation bias. You looked around the world to confirm the data that confirm already you have. Whether it's in the medical field, you see a lot of the consultants in the public, everyone looking for that confirmation bias of you already made the decision that COVID is no longer a serious disease, and I will look data to support it. But I gave the US data, and the great physicians who talk about, who care, it's at the level of stroke, diabetes, the topmost 5 killers, even for young adults. So COVID, which is an infectious disease, we should not be even in top 10, even 20. Top 20 in industrialized rich countries are now top 5. And that's really, everyone is contributing to that complacency and saying, underplaying the danger. So you have a disease with an accelerated evolution. You have tools that are incredibly good and effective, but there's a massive barrier of trust, and people say, oh yeah, you underplay it, and oh, it's not a big deal. But it has taken between 6 million to 16 million if you add the number. So it's that constant undermining of comments, even from respected colleagues who are well-known, especially in the field, saying minimizing the effect of COVID, and then the public listening to those experts who say, no, it's just like the flu. We've been saying for the last 2 years, just like the flu. No, it's a virus that has not found its ecological niche. Maybe one time in 5 years or 6 years, I don't know. No one has a predict. We have not yet reached. So it's a virus still struggling, still driving 200 miles per hour, crashing in all the vulnerable. So how do we rebuild that trust between the population, between individuals, between communities, so that we can have share? Now supply is no longer an issue, it's a trust. Even in some of the countries where the vaccine is available, the community, wherever mistrust is, misinformation going in these rich countries, we're all connected to the same network, the same Twitter, the same Facebook is having. So how do we build the solidarity required to get out of this? Yes, there will be Omicron, BA4, BA6, there will be Pi, there will be Sigma, all that will come. But if we rebuild that trust and come together and say this is really a dangerous top number 3, number 4, number 5 killer, COVID is not a simple flu or a simple respiratory. It will be eventual once we build multiple waves of it. But right now we require everyone together, and we are not yet out of this pandemic.
Abdi speaks there about that concept of, and I think it's a very important phenomenon in this pandemic, and particularly now, that idea of confirmation bias. So we've decided that COVID is no longer a problem. So from now on, we will only listen to data that suggests that COVID is not a problem, and we'll ignore all evidence to the contrary. And this has been a problem all the way through this pandemic, and something that's really concerns me is that what we have, normally the scientific process, the public health process, is to gather data, observe, look at the world, analyze that data, understand what that means for human populations, and define policies to control the disease or reduce the impact. So the policy is determined to a great extent by the data and the analysis of the data. So we call that data-driven policy analysis, right? And that's the scientific method, and that's what we always hope, that our policies are based on reality, okay, on some kind of scientific reality. What's happened to a great extent in this pandemic is we've had policy-driven data analysis, where policies are decided and then scientists and others in public health are asked to go away and find the evidence to support the policy. This is really, really dangerous. It's really dangerous, because that is not the scientific method, and scientists are not there to find the evidence to support policy positions of government or policy positions of politicians. It's not the way it should be. And it's increasingly, for me, a concern And when we talk ourselves to delude ourselves, and we do this in our own lives all the time, you know, if a friend of the family was getting married recently, and the weather forecast for the wedding was terrible weather, and they kept convincing themselves of all the signs that it was going to be a beautiful day, right? And it was amazing the evidence that was used to say, no, it's wrong, because this proves it's going to be a very nice day. So we all do that in our lives. When something is important to us, we want something to be so. We want the reality to exist. And we very often do have that. It's almost a protective instinct in humans. We delude ourselves, in a sense, by only looking at evidence that makes us feel like it's going to be okay. And that can be very protective of your mental health sometimes. But when you do that collectively, as a society, when you put your hands over your ears and over your eyes and you don't look, and you make assumptions, then it can be very dangerous. And I think we have to be really, really careful, not just in COVID, but in public health and in health in general, that we go back to a process whereby we respect the fact that we don't understand everything. There are no real easy answers to anything, that uncertainty is part of our existence, and that as we develop public health responses, there will be errors, we'll be right today, wrong tomorrow. And a decision made today can be correct. That same decision tomorrow based on a new reality can be incorrect. We've come into a world where it's all about right and wrong, and we've seen all this recrimination. It's about making good decisions based on the data you have at the time. It's about driving your policy with that data, and it's about trying to avoid that confirmation bias. And we're kind of at that point now with COVID, where people feel it's over. So the only data we're going to look at is data that says it's over. The only evidence we'll examine is evidence that it's over. And from a government's point of view, and that's fine, if the ordinary person in the street wants to believe that, fair enough. If governments start to believe that, it could be very dangerous. If governments start to think it's over and we're not going to have another wave and everything is going to be all right, we could be in for a big surprise. And they won't be ready. And the hospital beds won't be ready, and the PPE won't be ready, and the oxygen won't be ready, and the ICU beds won't be ready. Now, there was an excuse for that in January, February, March, April of 2020. Nobody was ready. But 2.5 years into the pandemic, everyone needs to be ready. And it doesn't mean we have to scare the lives out of people. I hope the greatest gift we could get this winter in the Northern Hemisphere is that nothing happens, right? We're not here to be, I can't remember the name of that movie about the Chicken Littles, you know, saying the sky's going to fall in. We're not here to say the sky is going to fall in. It's not our job. We're here to say that this virus has a lot of energy left in it. We have a complex immunologic relationship with that virus, and we have big immunity gaps in our society still. Those gaps are not closed enough, particularly in low-income countries. So this virus has the potential, with its current evolutionary trajectory, with our waning immunity and with our gaps in immunity through lack of vaccination, and still the huge inequities in health access that we have all around the world, this virus still has a potential to do a lot of damage. We hope it doesn't, but it still has that potential. So as we sit in June, the end of June 2022, we have to say that there still is energy there, there's still potential for this virus to cause trouble, and we have the tools, we have the vaccines, we have the antivirals, we have the knowledge to be able to combat it now. And if we don't apply those 100%, then we've really missed an opportunity. It'll be very hard to be back here in October, November, in the middle of huge waves of COVID infection and ICUs filling up, to be saying, oh, we should have vaccinated more people, or we should have closed the immunity gap, because we haven't closed that gap enough around the world.
Thank you both. I must say, definitely there are some people who earned your trust and who are leaving comments that they are still wearing their masks, and they're not giving up on that. So thank you for that. And I thank also to our viewers from Botswana, South Africa, India, Nepal, Indonesia, the US, Argentina, Norway, Pakistan, Sri Lanka, Mexico, Bangladesh, and many others. Thank you for your questions and for being with us today. Until next week, please follow the advice that Mike and Abdi gave us today and stay safe.